Okay, thank you very much. Thank Eli, thank Samir. Always a pleasure to meet two good friends. And thank you to Mindre, of course, and in particular to Fiona, Fiona New, because she forced me to think about this issue 1 year and a half ago. And I thought it was boring and old style and useless, and I was wrong. And these are my potential conflicts of interest. Okay, why I thought it was not such a big deal? Because, I mean, as you can see, I'm an old guy, and in my concept, monitoring is something used to convince me to change immediately the treatment of my patient, looking at something that is happening in that specific moment. And indeed, looking at the definition that Martin Tobin gave 33 years ago of monitoring, I was actually quite a lousy physician, because in addition to the concept of alerting attendants of changes of patient's condition, he also says that monitoring aims at aiding with diagnosis and therapy and to create trends that assist in assessing therapeutic response and predicting prognosis, which is far from my initial idea of monitoring, and that takes us directly into the topic. Does it make any sense to look backward at 24 hours monitoring? I think so, yeah, today I think so. This is a slide I presented last year in Paris that shows in green that this patient over 24 hours spent a lot of time in paroxystic supraventricular tachycardia. And this was despite treatment with beta blockers and calcium channel blocker therapy. And in the end, looking at this tracing, it was decided to proceed to ablation of an occult left accessory pathway. And after 24 hours after the ablation, we observed that there was a complete resolution. So we were able to assess the validity of the treatment, and we decided the treatment because we observed over time what was the impact of that specific problem. This is a bit more sophisticated. We know since more than 10 years, and there are two important studies, I believe, underlying this, that the prolongation in acutely ill patients of the QT interval, especially when corrected for the heart rate, is related with poorer outcome, which is increased hospital length of stay and worsening of hospital mortality. And we know that most of the drugs we use are potentially generating QTc prolongation. So if we combine these two, it might be interesting to monitor over time, because this is not something we are really interested at the moment we observe the patient. But looking backward, I want to show you two emblematic cases. This is a young girl, 19 years old, with a coma secondary to intoxication of amitriptyline. And she received endotracheal intubation and accepted after activated charcoal administration to my ICU, to our ICU. And please note, in the first part of the screen, you see we started the sedation with propofol and remifentanil, which is our standard of sedation in just admitted ICU patient. After a while, she started to become awake, and so, as we do by protocol, we replaced the propofol with the dexmedetomidine, leaving remifentanil unmodified. And if you look in the upper tracing, the black one, that is the duration of the QT corrected, and you see that over time, after we started dexmedetomidine, we started to get close to the area of prolonged QTC. Then we interrupted dexmedetomidine, the patient was getting better, and you see that immediately there was a decrease in the QTC value, which tell us that, I mean, we do this scheme of treatment basically in all patients who are intubated and wean off the ventilator. And, you know, sometimes it is probably useful also observe other aspects which are not strictly related to the management of our patients. Now, this is the second case, a liver transplant in a 62 years old, and in day 6 after the replacement of the organ, she had ventricular tachycardia, which was resistant to amiodarone, and remarkable QTC prolongation. Amiodarone was stopped, the patient was admitted to ICU, and you can see that after 5 hours after admission, we observed a sudden increase in QT, and we observed that this was getting close, very close to severely prolonged QTC, which may be extremely dangerous in a sense and lead to arrhythmias. And we administered magnesium, as you can see in the white-blue label on top of the picture, and the patient suddenly evolved positively, and the prolongation went down to normal. But where I believe, and we are doing some new things on this, where I believe there could be something interesting is the issue of weaning. Today, we know we have several indexes which are often used in not exactly in the right manner. And for instance, one of the indexes most useful, I believe, is the rapid shallow breathing index. Now, I want to be clear. What I'm showing you is not the proper use of this index. Martin Tobin developed this index just at the beginning of the interruption of the ventilator support. 1-2 minutes. You don't see the RR over VT ratio go above 100. You can keep doing the spontaneous breathing trial. It goes above, you interrupt the spontaneous breathing trial. This is the way it was designed. But let's try to change the paradigm. This is a patient with ARDS secondary to pneumococcal pneumonia, and look at this tracing. This is more or less from 4 to 10 and from 10 to 16. In the upper part, the pressure support level was 10 and the PEEP level was 8. The rapid shallow breathing index was around 50. The red line is the moving average, just to correct for spikes and variations. In the lower part, which is continuing the time, the pressure support was reduced down to 8, and people left unmodified, and you see nothing changed. So, 12 hours from the beginning of the tracing, an attempt was made to interrupt the ventilation, and I mean, to make a long story, we prefer to go to 0 pressure support and 0 PEEP, which is not necessarily the best approach, but is our approach. And you see that again, the rapid shallow breathing index was modified and the patient was successfully extubated. In the same period of time, we could measure the p.1 that was not changed again and remained within the value of normality. Other patients, and in this case, this was a lung transplant. He had been already tracheostomy. I remember he had a lot of complications. Anyway, we start with 50-55 of rapid shallow breathing index with pressure support of 10 and PEEP of 8. But in this case, when we move from a 10 to 8 of support, what we see is that there is an increase in the rapid shallow breathing index. And in the end of the second line, when we attempt a PEEP 0 support 0 trial, a spontaneous breathing trial, suddenly we get a value which is above the 100. Back to pressure support 8, PEEP 8. Several hours after, we try to decrease the amount of support from 8 to 6, which is apparently peanuts, but it's not. And the value of the rapid shallow breathing index get again up. So we decided to move the patient to a long-term weaning center for weaning of the patient because it was going to take forever. Another case, p.1, you see in this case, which is a different RDS patient. In this case, we stop ventilation, and you see that the p.1 goes up above 4, which is probably something that should alarm us on the possibility to win. Now, if we put all these concepts together, we might be able, using data which might be the p.1 combined with the rapid shallow breathing index, combined with the SpO2 FiO2 ratio, combine whatever we decide to combine. And I took data from an old study, which was negative, I never published, but it was a multi-center trial. And we used these 142 patients to develop a training set and then made a validation on 36 patients and tried with our statistician different models. The interesting was that the artificial intelligence model was the best, the one with the best accuracy, which was close to 0.8, which is not perfect. But thinking that these data were collected in a very rough way, in a sense, more than 10 years ago, convinced us that it is time to move to a prospective study with 18 baseline predictors and 2 daily clinical evaluation. And we are going to use a 24-hour continuous monitor from the mean drain monitor we have. And we will use this approach, averaging 30 seconds period during the entire period of the patient admission to the ICU. And the primary outcome will be successful extubation. So the idea is using artificial intelligence to combine different information, being able to observe a variation that a trend toward one of the solutions, yes or no, in terms of successful extubation. Now, last, I'm pretty interested in this possibility. If you look, this is a shocked patient with a septic shock, but he was also a cardiopathic patient for an ischemic cardiomyopathy. He had peripheral artery disease and chronic renal failure. And he received, for severe hypotension, norepinephrine. You see the upper part of the slide is described the dose. And we increased progressively the dose with no chance to improve the mean arterial pressure up to 60. And we started vasopressin with, again, a limited success, and finally added epinephrine, 0.05, very small dosage, considering the value of the hemodynamic monitoring, the vascular systemic resistance, and so on, and we were able to improve the arterial blood pressure. This information was not possible to achieve just at the sudden observation of the monitor at the time all these events occurred, and looking backward, we were able to identify a patient with probably a huge problem of poor response to vasopressors. Thank you very much for your attention.
Thank you very much, Paolo. We have time for comments. Maybe one question, clarifications, or maybe shared experience. Paolo, I'm very interested by the use of the data monitoring as you presented it. It can at the same time be the CRF for a study. But I'm interested, because we are going to look at the future in the next presentation, I'm interested on how we can explain things that happen. So how can you make, because of course we can only make associations and there are many confounders, for example, yes, therapeutic interventions, you show yourself that you are dealing with drugs, but we have to. So how can you make associations between the things that you observe and the baseline data? Because we need to adjust on so many different things, and this is going to be a challenge, as is going to be the main sources of data for the future.
Absolutely, you're right. One aspect is identify problem, which, of course, there is nothing without confounding factors in medicine, so we know. But there are aspects that are probably less problematic from this point of view. I believe that the probability to identify patients ready for successful extubation is one of those. Second, I learned that one of the positive aspects of the artificial intelligence, and depends a lot on the number of data and patients you crunch, is exactly the ability to get rid of confounding factors in a manner which is rocket science for me, but my statistician showed me very interesting data in this regard. I think this is probably the future for monitoring and probably mechanical ventilation too.
Thank you very much, Paolo. Any question, comment, maybe Samir?
Thank you, Paolo, for this nice presentation. Do you success to have some data with your mathematician and statistician to prevent the occurrence of some adverse events, such as you present tachycardia, the increase of QTc, etc.? Because there are some data available now in anesthesia care, in OR, and in the data that you show, is it possible to say that, oh, this difference or these signs should inform for an occurrence in 2 minutes or 3 minutes of tachycardia? Do you have now data like this?
This is what we are planning to do. We have a very small set of data, and so far what we have reanalyzed all data from a big randomized control trial. But in that study, we only had respiratory variables, which are not sufficient, as you probably suggested in a sense. And I think there is a lot of good stuff inside that approach, but I don't have good data at the present time to say yes. I think it's there.